accurate diagnosis, a significant clinical challenge. For this case specifically, it takes us about even greater challenges, requiring ongoing reassessment, multidisciplinary input, and individualized care. Right, this case will illustrate the real-world complexity of psychiatric diagnosis and a long-term management. All right, I'll be presenting a case of a 54-year-old Chinese lady with a long history of mood and psychotic symptoms, complicated by multiple suicidal attempts, substance use, and poor treatment adherence. Over 9 years, her psychiatric presentation unfolded gradually, layer by layer, before we were able to arrive to the most appropriate working diagnosis for her. All right, her symptoms first started back in 2001, when at that point of time, she was about 28 years old and she was living in Penang. She presented with auditory hallucination, whereby she had multiple voices, second person commanding. She had visual hallucination, seeing ghosts, spirits, soft toys talking, heads banging on the cupboard. Bizarre delusion, whereby she believed that the deceased husband appearing as spirit with another woman. The husband was still alive. And there's also a persecutory delusion, whereby she believed that her friends intended to harm her. These symptoms has caused marked functional deterioration in her life that she was brought to a private psychiatrist in Penang. With the available information at that time, she was treated as schizophrenia and she improved with antipsychotic, whereby she defaulted after 3 years due to subjective cognitive slowing, emotional blunting, and weight gain. Only later on, retrospectively, that we have information regarding polysubstance use. Right. Her first contact with us was actually on 16th of May 2007. At that time, she was para 3, 4 months post-delivery, and she was at the age of 34. In between the 2001 presentation until 2007, she has actually remained asymptomatic. Right. She was brought in by her husband with overdose of alprazolam. She took about 30 tablets of alprazolam at that time after a marital conflict. She was noted to have depressive symptoms. She had low mood, anhedonia, insomnia, poor appetite, guilt, worthlessness, and suicidal ideation. At that time, it impaired her maternal functioning. She couldn't take care of the daughter. And during the presentation to us, there was no psychotic symptom that was elicited besides the history in 2001. We corroborated with the husband. We noted that she has long-standing impulsivity, poor anger control, and also prior history of self-harm, whereby she was using a knife to hurt herself after an argument with her boyfriend. She admitted to extensive polysubstance use. However, during that point of time, it was only in the past and the urine drug test was negative. So she was treated as schizophrenia due to the previous history. Major depressive disorder, postpartum onset, that is what we get from the current presentation to us. And also, it was mentioned that she had borderline personality traits. So from 2007 to 2012, which is about 5 years, at the age of 34 to 39, she had about 8 admissions for depressive episode with suicidality. During this period of time, we managed to catch symptoms that point towards bipolarity, which are overspending, increased goal-directed activities, reduced need for sleep, and as well as elated and irritable mood. She had recurrent impulsive overdoses and self-harm. We noted that she also presented with the history of psychosis. However, it was not consistent and there was no strong evidence for it at that point of time. So, with the information available, she had depressive symptoms in the past, she had hypomanic symptoms during this 5 years period. So, she was treated as bipolar 2 disorder with borderline personality traits. We treated her with antipsychotic, which was quetiapine, antidepressant, which was Luvox, as well as mood stabilizer Epilim. But the Epilim was needed to be taken off later because she had a history of overdose requiring ICU admission with Epilim. Right. So at the age of 41, that time was already in 2014, the range was about 2014 to 2016, she had another 4 more admissions. However, during this period of time, the presenting symptom leading to the admission is more psychotic rather than mood. She presented with disorganized behavior, aggression, insomnia up to 4 to 5 days, auditory hallucination, as well as persecutory delusion. Urine drug tests during this 3 years' time were positive for methamphetamine and amphetamine. However, the psychotic symptom persisted despite episodes whereby the urine drug test was negative. She admitted to using amphetamine, and by using amphetamine, it actually worsened her hallucination. So, as we noted that the psychosis persisted despite no substance in her system, we've explored further about Schneiderian first rank, and we noted that she has a few wishes: thought broadcasting, delusion of control, passivity experiences, and fixed persecutory delusion. All right, before we go to the diagnosis purpose, I'm gonna, because you notice now that she has a lot of psychiatric symptoms, and also on top of that, she also has substance use. So I'm gonna share to you a bit more about her life so that we understand why the substance is in the picture. All right. She has hypothyroidism on levothyroxine, hypertension on temesartan. She also has asthma and history of low segment cesarean section. Her life is very colorful. So during her childhood, she was adopted at birth. She was sold off by her own parents for about 600 ringgit. So she had normal delivery, but noted frequent illness during her childhood. There are no further information about her biological parents. During her childhood, during her early childhood, around the age of 3, she had a lot of childhood abuse, physical, verbal. Her foster father was pictured as an alcoholic, and the foster father was pictured as someone who doesn't want her in the family. The foster mother died when she was about 15 years old, and she was taken care of the foster grandparents. So she only studied until the age of 13, whereby she was dismissed at the time. There was a documentation suggested that mentioned that she was abducted and actually forced into prostitution before she was dismissed. She was rescued by the police, and then she was admitted to the rehabilitation center. She only stayed there for about 1.5 years before she ran away. So she didn't continue study, and she started to find works to actually sustain her life. She did multiple unstable jobs. She did bartender, hostess, waitress, promoter, saloon girl, and also being a clerk. For her relationship history, she actually was in 3 major relationships. The first one she met while she was working at the CRO. The husband was Singaporean. She married for 17 years. They divorced as the husband was having an affair. They had 1 daughter, but she had to give away because she couldn't take care of the daughter. The second marriage was while she was working as a promoter. The husband was a gangster, physically and mentally abused, and the husband was abusing drugs. So they divorced. They also had 1 daughter, but she had to give it away because she couldn't take care of the daughter. The third marriage, and which stays until now, is from the age of 33. It is only a customary marriage, no legal marriage procedure. Husband is a taxi driver. So the substance history, she admitted during our so long encounter with her, right, so many years of encounters with her, we were able to collect that she has been having early polysubstance use since teenage years. She used cannabis, ecstasy, pil goyang, aramine 5, and also amphetamine. She did have history of hallucinatory experience at the age of 15, but from 2014 onward, it is mostly amphetamine, methamphetamine. There were tolerance and withdrawal symptoms noted. There's clear temporal link to psychotic exacerbation. She did has an alcohol misuse in her youth, and she smokes about 10 cigarettes per day. Pre-morbidly, she was described as extroverted, long-standing impulsivity, poor anger control, and prior history of self-harm. During the first initial contact with us, she doesn't really show any blood abnormalities except for the metabolic profile and the thyroid. So the thyroid was referred actually, and she was treated, and there was no recorded imaging. So if you go through the history, right, though we managed to peel one symptom by another over a period of 9 years, so by this time we have gathered that she at least have 1 major mood episode. She had a lot of depressive episodes. We also have history of hypomanic episode, right? And then she did fulfill the criterion A for schizophrenia, whereby she had delusion, she had hallucination, and she also has disorganized behavior. So we also noticed that she has hallucination in the absence of any major mood episode, especially during the 4-5 years until 2016. So mood episodes are present for the majority of the total duration from the 2007 onset. So in November of 2006, we made our final working diagnosis revision. The key clarification point was that the psychotic symptom present outside of mood episode, and the psychotic symptom present outside of substance use. So by 2016, moving onward, our final diagnosis came as the first one is schizoaffective disorder bipolar type. Number 2 is stimulant use disorder, and number 3 is borderline personality trait. But if I can bring your attention, so by November of 2016, we already get a diagnosis that fits her and would eventually help her in the process of recovery. But that is only the first part of her psychiatric journey. We did come up with that diagnosis, and from this time onward, we optimized the antipsychotic, which was quetiapine, which is also covering for mood. Right. So, however, we found that she was still not getting better as we had expected. Our medication, we do notice that our medication actually worked for her. When she takes the medication, she does get better. However, compliancy and illicit substance use complicate the process of recovery. So every time she defaulted the medication, every time she takes the substance, she will relapse and she will still require admission. Imagine from 2007 until 2016, which is about 10 years, right? She required about 12 psychiatric admission with 1 medical admission due to psychiatric condition, right? So over time, our inpatient and clinic-based management become increasingly, the options become increasingly limited with repeated relapse and admission. So we choose to get the help of our community and rehabilitation psychiatric team from July of 2006. So during our home visit, our clinic visit, we noted 2 main major issues in this patient. One is the poor compliance of medication. She was only on quetiapine 450 on night, clonazepam and zolpidem. Patient refused for LAI. You have to understand that when we visit her, we cannot force her to get the injection. So we try to get some autonomy from patient for decision making. So she strongly refused for LAI. We did try a lot of give and take with patient. And we noticed that she had a very colorful life experience with no proper support system at all. Although every admission we met her husband, the husband was there physically, but not really involved in her supervision and her treatment process. And the second issue is the ongoing substance use. We did advise her on not taking substance. We did try to psychoeducate her about how substance will worsen her condition. However, with home visit, we actually managed to understand that in her living environment itself, there's a lot of drug pusher there, and the drug pusher will knock on the door and even find her just to sell substance. So there's an unhealthy environment, neighbors who are drug dealers who always comes to find her. So during years of the community visit, the community team became the support system that she needed to overcome these challenges. So the details of how our community team helps her, that is beyond medication, I will leave that to Puan Fida for the next talk. But I would like to show you all how she progressed from someone that requires 12 admission in the span of 10 years. She becomes someone that can comply with the oral medication. She remained abstinent from the substance despite unhealthy environment. There was no more admission since 2016 after the initiation of community. She is able to return to work by 2017. She secured her own work. She sustained her own work. Patient care managed to step down from community visit to outpatient clinic, in which she was compliant and she came according to her appointment. She demonstrated relative clinical stability despite she has residual auditory hallucination and occasional low mood. And she was able to care for her children, for her daughter independently until, now the daughter is 19. She's managed to take care of her daughter independently until the daughter can further study into higher education. All right. And surprisingly, because community team became the support system that she never had, she will happily, regularly update community team about the progress of her daughter. So for the details of the community, how community team help patient to recover to this point, I will let that Puan Fida to explore later, to explain later. With that, I will conclude my presentation and hand back the floor to Prof. Chan. Thank you.
Thank you very much, Dr. Adli, for the very clear presentation. So now we would like to invite Puan Fida, our occupational therapist, to explain a bit more the specifics about what kind of OT experience that has been beneficial to the patient. The floor is yours, Puan Fida.
Okay, Assalamualaikum and very good morning, everyone. Thank you, Prof. Chan, and I will continue after Dr. Adli. Okay, today I will be sharing a community psychiatry rehabilitation case, and this case is presented using the model of human occupation to explain how recovery was achieved in the community. Moho helped us as an occupational therapist to understand recovery by looking at motivation, roles, habits, abilities, and the environment, and rather than symptoms alone. Okay. So from repeated relapse to community recovery. So in 2016, the client was referred to community service due to frequent relapse, medication issues, and declined functional performance. Although symptoms being repeated relapse, she was unable to function consistently in daily life. From Moho perspective, repeated relapse had significantly affected her volition, particularly her personal causation, belief, and her ability to sustain. So at the same time, the existing environment did not support sustained role participation, which led to occupational background. So the issues is because of the medication adherence and illness control, and also reduced functional performance in her daily life. So she require occupational therapy intervention beyond ward-based care. So from patient from hospital, house, and we further to work. So we go next for multidisciplinary stabilization. So following referral, the multidisciplinary team, particularly the psychiatrists, doctors, and nurses team, focus on the illness control, medication stabilizations, and this phase is very crucial as the rehabilitation cannot begin effectively without a stable performance capacity. So within the Moho, this phase is support to performance capacity, ensuring that mental states are stable enough to allow rehabilitation to begin. So the home base started, so rehabilitation then begin in the client's home environment through a community visit, which is home visit that we have done by multidisciplinary team, and our occupational therapy focus on restoring her meaningful life roles as a wife, as a mother, community member, and also a worker. So working in her real life context allow OT to understand how illness affected her daily routine and her role performance. So for occupational therapy, rebuilding life, not just the symptoms. So at the first phase, we focus on the assessment and understanding a life. So we look first on the occupational profile, which is go for her role history, performance pattern, interest and motivation, work readiness, and also social communications. So a comprehensive OT assessment was conducted to identify other contributing difficulties, and it's included a few assessments that had been done for these cases. So to understand these cases, Dr. Adli has mentioned before, so we go to the occupational profile. So as mentioned before, Mr. C is a 44-year-old Chinese female, married, being diagnosed with schizoaffective disorder, and live with her husband and 19-year-old daughter in the second floor flat in the Cheras. Then she been referred to community services and occupational therapy since July 2016. And due to recurrent relapse and unemployment and also psychosocial functioning difficulties. So primary roles, she is a wife, mother, and community member and workers, as mentioned previous. And previous work role, she started working since age of 14 at Petaling Street. Then she quit job and working at saloon few months, then tried another job at nightclub as bartenders, and changed another job as a sales girl at Sungai Wang, then changed again until the last job was as cleaner at exhibition and the one of the international university. So, but now she currently working as a restaurant assistant, assist in customer service and also cashier. So most of the termination of job because of the interpersonal conflict, emotional instability, and also relapse episodes. So Mrs. C has a very long working history, indicating a strong vocational identity but poor job sustainability due to her mental health instability and psychosocial challenge. So we can go for occupational performance also in the physical environment. As mentioned, she lives in a family flat, second floor, and then in the social environment, lack of family support, especially by her husband, and limited spontaneous social interaction, engagement with neighbors, and easily being targeted with substance pressure. And for the cultural spiritual context, is Christian belief, no culture barriers identified. So this is a comprehensive OT, occupational therapy assessment had been done for this patient. We conclude all the area which is activity of daily living by using modified Barton index and functional assessment ability, and then we assess using instrumental activity of daily living by using Lawton IADL, leisure to assess on leisure participation, rules participation, psychological and emotional regulation using DAS and PHQ-9, social and communication using ACHIS, rest and sleep by using PSQI, and lastly we use work and leisure, active employment readiness, and Becker work evaluation profile to assess more on the work performance. So for the ADL, so basically this patient is very independent in basic ADL, but she's require minimal reminder for personal hygiene, which is lack of awareness in maintaining her body odor and also clothing cleanliness. So for IADL, scoring 6/80 indicates that mostly independence in IADL, but she's require assistance in the housekeeping. She able to perform the house chores, but cannot maintain acceptable level of cleanliness. Then in financial management, she's very impulsive spending at that time. For the rest, and sleep score PSQI, inconsistent sleep pattern, and significantly poor sleep quality. For the leisure and interest, having a specific leisure, but not structured. For the social participation, we're using ACHIS. She scored from 20 aspect of social skills, and 40 aspect rating under support, and another 6 aspect of social skill are interfere, which is related to her expressing desire, refusal, and request. So we conclude that related to the assertiveness skills. So for the work and productivity, she demonstrate readiness for work, ready for work at the moment, and she in a competitive job stage with support needed. So the issues is she has low self-confidence and very poor stress tolerance at work, struggle adapting with illness symptoms, poor coping and difficulty to manage her own stressor and triggered at workplace from the colleagues, and also very unstable to sustain her job. Okay. For the cognitive function, MSE 28/30 indicate normal, but having difficulty in maintaining attention and concentration, especially when she's very struggle with illness control. Okay. For the psychological and emotional function, still ongoing auditory and visual hallucination, but manageable, irritable mood, easily being provoked to anger, and also easily frustrated and very poor emotional regulation. For the insight and motivation, a very good insight to the illness and relapse signs, and complying with medication, and very highly motivated to work and improve functioning. So this is what was blocking on recovery. So based on assessment findings previously, so we can see there's a few aspects that blocking her recovery. Firstly is her difficulty to maintaining employment due to the illness control, very poor emotional regulation, and anxiety and low self-confidence. And she's also having difficulty to maintain level of her house own cleanliness, spending spree, impaired social and communication skill, assertiveness skill, coping skill, and also having difficulty in sustaining attention and also sleep issues. This is the issues that we get from the assessment that we have done before. So the rehabilitation will focus on the Mrs. C occupational performance, which is her emotional regulation, social participation, and vocational readiness, in order to support her to sustain employment and to be in the very good environment of community. So we have, based on the assessment of finding, so the intervention will focus on establishing the daily routines, so then her role balance and strengthening her emotional regulation, as they were identified as a key barrier affecting her participation, particularly in works and community setting. And then we can see that from Moho, the change occurs through doing and repeated engagement. That's why we are focused next to the intervention, so we can achieve on the intervention and short-term goals. So for the short-term goal for this patient, we hope that client will demonstrate effective coping strategies to manage her anxiety, her frustration related to work tasks, work activity, and improve personal hygiene, especially when she's going to work. Practice a basic assertive communication, at least she can use that skill with the colleagues, and will sustain attention during the tasks that are work related. Okay, for the long-term goals, we hope that she's maintained her emotional regulation during work with minimal support from us, maintain independence in ADL and IADL, show improved social interaction and assertiveness, demonstrate appropriate money management, and also being engaged in supported employment or job placement. So as intervention progress, the client expressed a strong need to earn income and be financially independent. So work was highly meaningful to her identity. So at this stage, OT shifted focus toward exploring productive work skills and work readiness. So with emphasis on the job sustainability and also the short-term placement. So, okay, this and in the phase 3, we go for the skills building in the real life. So before we go for work skill for this patient, then we set up first with the daily routine and role balance activity scheduling for this patient. Focus on ADL, IADL training, emotional regulation, social skill, and assertiveness. So in the phase 4, after intervention progress, then we explore on the functional skill that related with work, which is we focus on exploration of productive work, identify strong needs to earn income and be independent, and job sustainability. So this focus on her own values and also motivation. So there's a few interventions that we have done for these cases. First is emotional regulation. We educate her on relaxation technique, deep breathing, PMR, mindfulness-based activity, emotional identification and regulation training, and stress management. All these interventions had been done at her home and also in the workplace setting. The second intervention that we focus in ADL and IADL training, personal hygiene checklist, weekly routine establishment, household task scheduling, and also money management education. And the third one, because of having issues with attention and concentration, we also focusing on cognitive training activity through graded task complexity to improve her attention and concentration. And then for the social and communication, had been done at her home and workplace, focus on the assertiveness for role protection. So assertiveness training to become a key intervention focus for this patient. She had difficulties with expressing needs, setting boundaries, and managing workplace stress. So which previously contribute to relapse and substance involvement. So through repeated role play that we use in this assertiveness component, so the skill were strengthened to protect her roles, maintain employment, and support relapse prevention, and reducing the vulnerability to involve in substance again. So last is a supported employment that has been implemented. So OT will assisted with job searching, job matching, workplace oriented, and also site support. And some adaptation was done with patient at during her auditory and hallucination, and we recommend for using a earphone to manage her auditory hallucination at the workplace. So we use environmental modification to support participation and engage patient in a workplace. Okay, after all the intervention had done, the next approach that we use is to sustain work and recovery outcome. So in order to maintain employment longer than pre-rehabilitation, ongoing challenge are present but manageable, but for the moment patient have had no relapse or any psychiatric admission in the ward, and role maintained with ongoing support. So for the all assessment, ongoing assessment, reassessment, and also intervention, so as an outcome, she was able to maintain employment till now, and significantly longer period compared to before he being supported by community services. Although she having challenge in maintaining and struggle with her illness control, she has not having any relapse for the moment, and according to Dr. Adli before mentioned that by now he maintained her role as a wife, as a community, and also as a worker. Okay, so what enabled her to recovery till now is from the illness stabilization by a multidisciplinary team, meaningful role engagement till now. Even we now not doing home visit for these cases, but we support at the workplace, and we use skill-based intervention and occupational-based intervention for maintain patient capacity. So a very good rehabilitation prognosis for this case because of her strong motivation, good insight, and compliance with treatment. So this case demonstrates that recovery in mental health is not a single event, but it's a journey. Inner stabilization created readiness, occupational therapy restore roles, routine, and supported employment to sustain recovery and through meaningful occupation and environment. Now she able to regain and back as a role in the community and to improving her self-esteem. So recovery happened not when symptoms disappeared, but when she regained control over her daily life. So, thank you. Okay.
Thank you, Fida, for the very comprehensive overview of how occupational therapy can actually help a patient whom many might think, future may not be so great, but I think her illustration has shown us that it is very possible to support patients like that. So without further ado, I'd like to invite our last speaker, last but not least, Prof. Azlin, the consultant in charge of this patient, to present her talk. Thank you, Prof. Azlin.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and very good morning. Thank you, Prof. Chand. Right, so I will be the last speaker, right? Won't take long, maybe around 10 to 15 minutes. I just want to sum up, okay, our case discussion today. So currently I'm in charge of the community team. The reason I bring this case for today's CPC is to show to all of you the importance of community and rehabilitations. Yeah. Right. So you have heard from Dr. Adli. You have heard from Puan Vida. So among the problem list listed here, if you realize there's a dual diagnosis here. Yeah, there's a dual diagnosis, and the main issue of poor compliance, which lead to frequent relapses, and patient had poor social support. If you have heard about her background, you know, from a very challenging childhood, yeah, she was being sold to another family member, she was being adopted, so-called sold and adopted, and she needs to work to survive. She's having psychiatric illness, she involved with substance, so life is very colorful and challenging for her, right? But the good thing is that she's sick for help. She's sick for treatment. That is the good part. She's sick for help. She seeks for treatment. So initially was in Penang. After that, she moved to KL. So we have a primary team of managing her case. But they noticed that of the frequency of the relapses, too, quite frequent, more than 12 relapses, you know. So they feel that this case need to be referred to the community psychiatry. So what is dual diagnosis? So dual diagnosis means an individual have a mental disorder and a substance use disorder at the same time, right? So the dual diagnosis is used interchangeably with comorbidity or co-occurring disorder. So when these conditions occur together, the effects of each can worsen, right? If you have an untreated mental issues can cause substance use problem to get worse. So vice versa. And when the substance use increases, mental health problems also may be worsened. So now, numerous studies showed between 29 to 85% of individuals globally with mental health issue have co-occurring substance abuse disorders. And we have our own local study by Noliza Chemi et al. A study in Malaysia indicated that 63% of patients with substance use disorder treated between 2018 and 2021 had a history of psychiatric illness, of which 15% had depression, 17% had schizophrenia, 21% had psychosis, and 37% had other psychiatric illness. Right, what could be the causes of dual diagnosis? Of course, genetic predisposition make you more vulnerable to have psychiatric illnesses. So some people inherit a higher risk for mental illness and addiction. So for this patient, it's quite difficult for her to establish this genetic predisposition because she's being adopted. She does not know her own biological family, right? So environmental factors, okay, so environmental factors play a major role in causes of her dual diagnosis here because she has gone through a stressful life event, a traumatic life event, and she's been living in an environment where substance abuse is common and can increase the chances of dual diagnosis. So self-medication is quite common also, all right? Self-medication, people suffering from untreated mental health disorders sometimes use drugs or alcohol to relieve symptoms. So when you talk about substance, it's drugs and alcohol, illicit drugs and alcohol, yeah, to relieve symptoms, which can lead to addiction. Some patients, they do have anxiety. They need to do presentation. They cannot manage the anxiety. They does not come forward, but they do take alcohol to overcome the anxiety. Some people do have some sleeping problem. They do take some drugs or alcohol just to facilitate sleeping issues. All right. So self-medication, okay, can be the causes of dual diagnosis. Brain chemistry changes, both substance abuse and mental illness can alter brain chemistry, making it harder to break the cycle without professional treatment. And if there is a lack of early intervention, like I mentioned just now, where the patient have symptoms but they do not come forward, So without timely care, mild symptoms can escalate into more serious condition that coexist. So what are the problems with dual diagnosis? It can increase severity of symptoms and relapses, right? Patient can have more frequent inpatient and hospital admissions. Okay? Of course, there will be a higher treatment cost, and it will increase violence, okay, hostility, and involvement with the legal system. Other problem with the diagnosis, it can increase rate of homelessness and insecure housing, increased risk of retrovirus infection. Patient can have family problems. Patient can have financial problems. Among the main issue is a higher stigma. You have some mental illness, you have substance use issues. Of course, there will be higher stigma among the community, right? And patient could have a difficult to obtain and maintaining job. So, the treatment, again, there are few regime of treatment. It could be a serial treatment, parallel treatment, or integrated treatment. The serial treatment is that we treat one condition first, followed by other. You treat the substance use first, and then you treat the mental health disorder. Or we can go for parallel treatment. This intervention approaches focus on substance abuse and mental illness treatment at the same time. But the most commonly methods of treatment that we use is the integrated treatment, in which treatments are delivered at the same time, just like the parallel approach, but is coordinated by the same team members in the same treatment setting. Why this is important? Because we wanted patients to adhere to our treatment and management. If we treat the mental health condition, but the substance we ask other people to manage, there's a possibility that patient might defaulted, follow up either or. Okay, so it's important for the integrated treatment. So in the integrative treatment plan, of course, we have to psycho-educate our patient. When we talk about this, there's a lot of things that Puan Fida did. There's a lot of things of my community treating team do, but it's not done overnight lah. Okay, it takes some time. Okay? So psycho-education also is not that easy. Maybe you need many times to psycho-educate patients, okay, about the multiple disorder and bring insight into how each disorder influences the other, and we need to educate them about the etiological process, about interactive prognosis. So mental health illness and substance stabilization is very, very important in order to prevent the relapses, right? So in this case, as you know, patient is having psychotic symptom and also mood symptoms, so we treat them, we treat the patient using antipsychotic. And quetiapine also can help to manage the mood symptom as well. And we know compliance is the issue, right? You don't try to put patients so many medicines. You know, they might not be adherence to your medication. We try best, to provide patient as minimum as possible, but can control the symptoms. Then patient can adhere to medication. If you put 5 types of medication, of course, patient cannot comply to your medication. Dia akan lupa nak makan ubat, you know. So we try best to make patient feel, oh, it's easy to take medicine. Senang aja nak ambil medicine, ya. Of course, recovery reinforcement is important, sebab our aim is not for tak ada symptoms, you know. No symptoms meaning patient that okay, no. We are aiming at recovery because we have many types of medication and mental health disorder can be treated. Okay, tapi yang pentingnya adalah patient need to go back to the community, to go back to the punya family. So recovery is very important. Okay, either socially, okay, employment, okay, a patient must be physical and mentally healthy. Right, and of course we have to take note on the issues of substance, suicide, and also violence in this patient. Right, that's about dual diagnosis. I just wanted to bring to highlight. This is meant for students. It's about our community psychiatric services. So long time ago, if you have a mental illness, you're being isolated to the asylum or to the psychiatric hospital. Jauh from your place, from your home, you know, you're being isolated. So in Malaysia, we still have like Hospital Bahagia Ulu Kinta, we have the Hospital Permai in Johor Bahru, we have one in Sabah, Sentosa, we have one in Sabah is Bukit Padang, Sarawak is Sentosa, right? And last time they have about 5,000, 6,000 patients there. But now, we are now with the medication that we have, kan? Kita ada medication semua, we don't keep patient dekat the psychiatric hospital. Okay, patient need to return back to the community. Patient need to return back to dia punya family members, society, right? So now I think the most maybe around 900 to 1,000 je per hospital. Daripada dulu 5,000, 6,000 patients dekat situ, right? So we basically we are downsizing, kan? Downsizing the patients who stay there, okay? So kita dekat community ni we have to take care of them, okay? We really have to take care of them. If not, we just be like revolving door. You go there, treat, patah balik, no one want to help you. So dia akan admit balik dekat psychiatric hospital. Okay? So community psychiatric services focus on treatment, prevention of relapses and rehabilitation within a community setting, aiming to provide accessible care and support while avoiding unnecessary hospitalization. Yeah. So in Malaysia, our community psychiatric services has been gradually incorporated into the existing services since 1990s. Yeah. This is meant to increase service accessibility by the population and support the downsizing of mental hospitals. So community psychiatric services secara besarnya we give into two, community mental health services center and hospital-based community psychiatry. So community mental health service center ni, they have two parts. One is by the klinik kesihatan. It's under MOH, klinik kesihatan. Yeah. So some of the klinik kesihatan, they have this community mental health services center, right? Family medicine do treat and see psychiatric patients. Okay, the complicated case they would refer to the hospital, but the simple case, continuation of treatment, they do treat patients. And some of them, if they have enough staff, they do some rehab program also. This one is by the KKM, our klinik kesihatan. And another one, if you heard about Mentari. So Mentari is not at klinik kesihatan, it's not in the hospital, it's some place which either you get that place, either you rent out, tapi normally ada people yang give you that place. So we run a community mental health services there also. So for example, in Putrajaya, there is a Mentari in one of the housing condominium tu, dekat lower part tu, dia ada 2 or 3 units tu, they give to Mentari to run the community mental health services. So patient do come there, do come there to do some rehabilitation, do go there to take their medication, okay? And of course, complicated cases, they will send to the hospital. So like in our HCTM setup, we have the hospital-based community psychiatry. We have a community mental health center in our hospital. So hospital-based community psychiatry services is made up of a multidisciplinary team that provide treatment and rehabilitation to persons with mental disorder at home or as near to home as possible and are based in all hospitals as stipulated in the Mental Health Regulation 2010. Right. So of course, it's a multidisciplinary team. Okay. When we treat patient holistically, kita kena ada multidisciplinary team. Of course, psychiatrists, medical officers, okay, the nurses, assistant medical officers, mainly kita manage the stabilization of the disorder. We have our occupational therapists to help for the rehabilitation program. We have our own counselors, and we do have our medical social workers to help. So medical social workers play a very important role also, okay, to the community psychiatry in terms of getting some help for the patient in terms of monetary, okay. Kalau patient tak bekerja, dia ada OKU card, kalau dapat kerja, ikut kelayakan, they can get about RM350 a month. But if patient willing to go back to work, they can get more, around 450 macam tu. But of course, it's being assessed by our medical social workers lah, right? And certified by us, whether patient betul perlu ke tak, yeah? And medical social worker also do help patient, certain patient, in order kalau misalnya they need to have certain medication which patient need to buy, they can help out also, okay? So hospital-based community psychiatry is meant for defaulted tracing, level 1 and level 2 follow-up. So some patients have more than one unmet need and will need regular home visit to ensure medication adherence to maintain their stability. So another form of services that we have is assertive community treatment and acute home care. Unfortunately, we do not have our acute home care due to kita lack of staff. So the things that we mainly do at our hospital-based community psychiatry is assertive community treatment. We do home visits, okay? And on top of that, at that place, patient do their rehabilitation program in our center. So assertive community treatment, some patients have multiple relapses and each relapse can be rather troublesome with aggressive behavior and disruption in lifestyle. A more assertive type of follow-up that ensure medication adherence, okay, helps patient meet their needs with appropriate psychosocial interventions will be required. So the criteria for the assertive community treatment is patient with severe mental disorder, especially psychotic disorder. Kalau in overseas, there are other types of psychiatric illnesses that do go for home visit. For us, because of kita ada memang lack of manpower, we mainly focus on the psychotic disorder, schizophrenia, schizoaffective, bipolar. But we are unable to go for other type of patients yang ada other type of illness. Of course, history of no adherence to treatment. Patient have frequent crises, admissions, and prolonged psychotic episode. And patient had comorbid substance abuse. So what is the objective of assertive community services is to provide psychiatric care in patient's own environment. So kalau kita bawa inpatient is important to stabilize the acutely, right? Inpatient is important to stabilize acutely. Then patient return back to dia punya environment. So the continuity of treatment tu kita perlukan for our patient to have that, So we have to look at patient's punya environment. What are the patient punya struggles? What are the issue that patient cannot comply to the medication? What are the support that patient do have? Okay, so kita akan do that during our visit, and to detect early signs of relapses, which once we be able to detect this, okay. And we manage to treat this, and there will be a delay admission to psychiatric ward. And of course, we want to ensure medication adherence, okay? We want to help to monitor symptoms and side effects of medication and to provide psychosocial interventions. So the other objective of ACT services is to empower the family and community inpatient care, to develop smart partnership with networking between hospital, to reduce stigma and discrimination, and to promote recovery of functioning and quality of life. So quality of life here is the most important thing, yeah. So the assertive community treatment services must be planned, implemented, and regularly revised to meet client needs. So the team will provide longitudinal care to ensure medication adherence and enhance role functioning of patients. So this patient do benefit from our psychiatric community services. Yeah? She had a challenging life with poor social support and living in a challenging neighborhood. The rapport that she had established with our community team, especially with her case managers, I think Stefana Junita and Puan Fida, she know that she had the support to become well and be able to take care of her family. Like Dr. Adli mentioned just now, every time dia punya, the doctor had exam result, she will text them, show it to them. She shared dia punya happiness looking at dia punya daughter punya results. Because she doesn't have that in the even the husband also does not care less about that. Right? So one thing I just wanted to highlight is about non-judgmental. We must be non-judgmental when we treat our patient. Yeah? When you become non-judgmental, the non-judgmental approach makes patient more willing to share sensitive or painful experiences. So it can encourage open communication by removing the fear of negative reactions. Therefore, patient will feel free to speak honestly, and case managers can gain a complete understanding of their situations. Right? So this clarity is important in tailoring the intervention and address the real need rather than the surface issues. Okay? So every single patient kita ada tailored intervention for them. So open communication reduces misunderstanding and strengthens the professional relationship, which can lead to a more accurate assessment and better outcomes for the patient's well-being. So this is, I think Dr. Adli also has summed up just now. We are very happy with this patient progress. Now patients have come to the clinic to take her own medication. Only when she's a bit in crisis, she will contact our case manager. And she's in the supported employment program also. And Puan Fida did monitor her employment progress over there. I think her 19 years old daughter now in one of the international university, right? We hope that this can break their punya cycle lah. Can they have a better living? All right. So thank you everyone for your attention.
Thank you so much, Prof. Azlin, for a very comprehensive overview of the case. So I'm not sure whether there's Kahoot. I assume there's no Kahoot. Any burning questions before we move on to the next program? Anything that you would like to not necessarily ask, but comment, or you want to learn more from this case, any observations, reflections, please come to the mic and ask or comment. Anybody? Yes, please, Hanif.
Assalamualaikum and good morning. Thank you. Congratulations, Prof. Azlin, Dr. Adli, and Puan Fida. Such a good presentation. Not a question, since Prof. Chan said not necessarily a questions. I just want to take this opportunity to highlight about one of probably a take-away message. I'm Dr. Hanif, by the way, under Community Psychiatric Service also, under Prof. Azlin. So I just want to highlight probably a take-away message from this case. This is one of the example of a double stigma case in which this patient have been stigmatized for her mental illness and also stigmatized for the use of substance ataupun substance abuse. So having a mental illness, is said, is a very difficult to reintegrate them into the community, plus substance abuse. So it makes double difficult lah. That's why always community will receive a complex case like this. So I just want to invite everyone to be able to spread this awareness of do the destigmatization effort in order for us to help them, because if you aware, there is previously Prof. Chan and the team works for the decriminalization of suicide, and recently we start do the effort of decriminalization of substance, in which it's become a public health concern rather than a moral value only. So probably this is one of the take-away message that I would like, at least for our students, to be aware from this presentation. Thank you, Prof. Chan.
Thank you so much, Dr. Hanif, for your very pertinent and updated comment. So now I'd like to pass over the time to Dr. Jane, who will come and introduce a very exciting event, especially for all our medical students. So as she is coming up, I'll just like to say that this particular event is very special because it's for the students. One qualifying statement is that it's not going to be, wait, hang on, I see this quiz and I see this feedback, but we don't really have to do this at this point, I think, if everybody's okay, because we need to move on to the next agenda. So as Dr. Jane is coming up, So it's Talk It Out. It's about mental health for you. I'll let Dr. Jane explain a bit more. Please do stay in the auditorium. Don't go anywhere. Call back your friends if it's possible. This is really something really special for you guys. So I implore you to stay back in the auditorium. Ya, jangan lari ya.